Good morning, good afternoon, and good evening, everyone. And thank you very much for joining us today on this ICAP Grand Rounds. I'm Wafa El Sadr. I'm the ICAP Global Director, and it gives me great pleasure to introduce this webinar and to tell you a little bit about our speakers who will be joining us today. Today's webinar is focusing on a very important topic. It is focusing on how we can use data on violence against children and youth in order to guide actions. And we'll utilize results from the VACS survey, which was conducted in Eswatini, and discuss the findings from the survey, as well as also the implications for policy and for practices as we move forward. I'm very happy to introduce the speakers this morning. We're very honored to have, firstly, Impo Mazia, and she is a social welfare officer situated in the office of the Deputy Prime Minister. She has a clinical psychology background, has been working in social protection and child protection space for over 7 years. She is passionate about this work and passionate about working with vulnerable groups, and has recently joined the VACS team as the DPMO team lead. She will be followed by Dr. Harriet Nuagaba Birinbo-Moha. And as many of you know, that Harriet currently serves as the research director at ICAP in Eswatini, and she's an assistant professor of epidemiology at the Columbia Mailman School of Public Health. She also leads a cooperative agreement to strengthen national epidemiological and research capacity in Eswatini, an award from the CDC and PEPFAR. She's also played a critical role in some of the population surveys that have been conducted in Eswatini, the second population survey, SHIMS-2, and the third one, SHIMS-3, which was conducted in 2021, as well as the 2022 Eswatini VACS survey. And lastly, we'll hear from Michelle Lee, and she serves as epidemiologist and strategic information branch chief for CDC in Eswatini. In her role, she plays a large role in overseeing and providing leadership for all of PEPFAR CDC strategic information activities, with a focus on surveillance, research capacity building, national population surveys, and many, many other activities, including monitoring, evaluation, reporting across the HIV and TB programming in Eswatini. So we're going to move on now to the speakers. I invite you all to please think about your questions anytime during the presentations, and please enter your questions in the Q&A box. And at the end of the presentation, we'll have an opportunity to go through your questions and have the panelists provide answers to these questions. So without further ado, I'm going to hand this over now to Impo Mazia. Thank you.
Thank you very much. Am I audible?
Yes, you're good. Thank you.
Okay. Thank you. Thank you very much for the opportunity to present the first segment. I'll basically be going through the background of the VACS in Eswatini. Could you please go on to the first slide? Can we move on? Thank you. So I'm going to start by providing the World Health definition of violence, which stipulates that violence is the intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group or community that either results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. Research has shown that any kind of adverse impact in the lifespan of an individual may have lasting impact on their physical health, their mental health, and their social well-being. The infographic highlights some of these effects of adverse childhood experiences, which include injury, mental health, maternal health, infectious disease, chronic disease, risky behaviors, and lack of opportunities. And those opportunities spread from education and so on and so forth. Next slide, please. So the previous slide, therefore, had depicted the importance of prioritizing research and work around the area of violence, which is why we are finding ourselves focusing on the work at hand. Violence in itself presents direct consequences against children and youth, which include the loss of life, failure to complete school, and the perpetuation of violence by victims of violence on others. The current slide depicts statistics from the World Health Organization stating that adults who experienced 4 or more experiences of childhood violence are themselves more likely to be involved in future incidences of violence as either victims or perpetrators, and are 30 times more likely to attempt to take their own life. Next slide, please. So what is VACS? The Violence Against Children Survey is a national household survey designed to capture the magnitude and prevalence of violence against children in a given country. VACS uses standardized survey methodology to collect comprehensive data on the prevalence and risk factors of sexual, emotional, and physical violence, the perpetrators, the event location, and the impact of the violence to inform intervention programs and action plans against violence. Please move on to the next slide. So in scoping violence, in scoping VACS in relation to the globe, Eswatini has had its first VACS in 2007. At the time, the country was called the Kingdom of Swaziland. For your confidence, I'd love to give a brief background of the Kingdom of Eswatini. It's a low-middle income country nestled at the southern part of Africa, as depicted in the arrow on the map. It shares its borders with South Africa and Mozambique. The country has a population of approximately 1.1 million people. To date, 26 surveys have been completed in 25 countries since the inception of VACS. Eswatini is one of the few countries in the world which has currently concluded its second VACS in 2022. Can we have the next slide, please? Delving deeper into the first VACS, it was conducted in randomly selected EAs, enumeration areas, and nearly 2,000 households, focusing on females aged between 13 and 24. So what this VACS has taught us is that Eswatini has a high prevalence of violence, as shown in the statistics in the slide. And findings have shown that more than 50% of all incidents of child sexual violence were not reported to anyone, while only 1 out of 5 cases sought help from available services. Again, it is these alarming stats that have sparked multi-stakeholder interventions to address violence against children in the kingdom. Could we please move on to the next slide? Post the first VACS, a multitude of activity in response at a national level has taken place. As a nation, we have embarked on a series of stakeholder interventions to address violence as a whole, with particular focus on children and women. The response was led by the Deputy Prime Minister's Office, the second highest government ministerial office in the land, whose portfolio responsibility, amongst others, is social protection, child protection, and gender and family issues. So 3 departments have played a crucial role in the response mechanism development for the Kingdom of Eswatini through the DPM office. These are the Department of Social Welfare, the National Children's Department, and the Department of Gender and Family Issues. Through these, national sensitizations and community education were conducted, and saw a rise to the enactment of laws to promote the protection of children and women from violence. Strategic partnerships with development partners ensured securing of resources to ensure that the implementation of response plans and mechanisms were in place. And to date, we have the following legislative frameworks as listed on the slide to drive the agenda of protecting and promoting the rights of children and women and the prevention of violence in the kingdom at large. Can we have the next slide, please? Thank you very much. I will now hand over to Dr. Harriet. Thank you.
Thank you, Mpo, for setting the stage. And thank you, Wafa, for the introduction and for inviting the Eswatini team to be part of the Grand Rounds. So for the next part, Wafa has done the introductions. I am Harriet, I'm with the ICAP team, and I'll just take us through the methods that we used for the Eswatini VACS 2022. This survey was led by the government, by the DPMO office where Paul works. And we did this in collaboration with CDC DVP, which has extended experience in the implementation of VACS survey. ICAP was the lead technical partner, and we collaborated with multiple key stakeholders as laid out by Mpo earlier. Next, please. So our survey objectives aligned with the global VACS survey objectives, where we set out to measure the magnitude and the nature of violence against children. We're looking at physical, sexual, and emotional violence. We then examined some of the health consequences, both on mental health and other risk behaviors. We also wanted to look at HIV prevalence and secondarily how that's associated with violence. We wanted to identify potential risk and protective factors, and then assess how people affected by violence have utilized services, estimate HIV prevalence in our survey sample, and collect data on indicators that Michelle will speak to a little later that sort of shape how folks reach out for help when in these situations of being afflicted by violence. Next slide, please. So the Eswatini VACS 2022, the most recent survey, used a 3-stage cluster sample design. In this design, we randomly selected enumeration areas throughout the entire nation of Eswatini. We selected around 353 EAs across 4 administrative regions of Eswatini. From those enumeration areas, which were selected for just over 2,000 EAs in the country, we then went to the second stage of sampling, which is randomly selecting 25 to 30 households in each enumeration area to participate in the survey. From the randomly selected households, we then randomly selected 1 eligible individual to participate in the survey. It's important to note here that we had a different sampling sort of approach for selecting enumeration areas where we would interview males and enumeration areas where we would interview females for safety of participants and just so to balance our data out and not have to perhaps interview perpetrators and victims at the same time. Next slide, please. Our survey procedures included permissions from parents or guardians. Our survey included individuals who were 13 up to 24. So for the younger individuals, we did obtain permission from parents. And then for all the participants, we had verbal consent. we administered a respondent questionnaire to the head of the household and then to the participants. Here, we ensured that we had same-sex interviewers, so male participants were interviewed by male interviewers and female participants by female interviewers. We then conducted HIV testing within the household, and that could be by survey staff, or if the respondent preferred, they could do self-testing as well. If we came across an incident or a reported incident of violence, we had linkage support to teams that could provide further support beyond what a cross-sectional survey can do. So we worked closely with the Deputy Prime Minister's office to link such participants to social workers. Those who tested positive for HIV, we referred for HIV care and treatment, and those who tested negative, we referred to prevention services. We did all this in the context of multi-level stakeholder and partner engagement at technical, community, and social worker level. Next slide, please. So this is how we defined violence in the survey. Where we mentioned childhood violence, this is violence reported by respondents who were adults during the survey. So those who were 18 to 24, but it would be violence that occurred before they were 18 years of age. So violence that occurred during childhood. We measured physical, sexual, and emotional violence. Physical violence being anything that includes slapping, pushing, shoving, or throwing things at someone, whipping, choking, or more grievous harm, like trying to drown or burn or threatening with a weapon. We measured sexual violence from unwanted touching to attempted forced sex to pressured sex and physically forced sex. We measured emotional violence, which could be perpetrated by a parent or an intimate partner or a peer that just included words, people telling the individual that they were not loved, that they wish they hadn't been born, people insulting the respondents and humiliating them or keeping them from social privileges, as well as any act that made the individual feel scared, excluded, or being called names. And when we report any violence, we refer to physical, sexual, and emotional violence. I'll add a caveat here that when you work out the permutations of the age groups we have and the variables we have quite a bit of data. So we will report on some of the variables and not everything we collected in the survey. Next slide, please. So this is the data we collected. We went to all the 353 years as planned. We ended up with actually more households than planned, with over 9,000 households and just over 6,000 females interviewed and 1,500 males interviewed in the sample. And this is important because you'll see that for some of the estimates, because we had fewer males in the survey, you will have some unstable estimates in some places, and those will be marked with an X. The data we present is descriptive, and in one or two places we have bivariate tables. The survey estimates are proportions that are weighted according to the probability of selection and the response rate and calibrated according to the census population. Next slide, please. So getting into some of the key findings. Next slide. Our participants who were 13 to 17 years old were mostly enrolled in school. We had about just over 20% who were orphans. A few of them worked for money, and we had just over 10% living with disabilities. And for our participants who were 18 to 24 years of age, about 10% of the females were married, about 1 in 3 were orphans by the time they were adults, and about 1 in 3 males worked for money and just over 20% females. And again, we see about just over 10% living with disabilities. Next slide, please. So this is our key outcome, which is our lifetime experience of violence. And our survey found that of the individuals who were in the survey ages 13 to 24 years, 25% of the females and just close to 32% of the males reported a lifetime experience of violence. Looking at the graph, the first set of bars is the vertical axis is the proportions, and the horizontal axis is the variables we measured. The first set of bars set up as orange for females and blue for males shows any violence experienced. And when we move to the next set of bars, you see that the experience of any sexual violence, followed by physical violence and emotional violence. What you see here is that for females, the violence experienced was more commonly sexual violence. And for males, the violence experienced was more commonly physical violence, and that for both males and females, the experience of emotional violence was relatively similar. Next slide, please. Here is the intersection of multiple experiences with lifetime violence. Just focus on the center where for males, 1.2% had all three experiences of violence. And to the left, for females, double that percentage had all three experiences. Around close to 7% of the females and 9% of the males experienced two or more types of violence. Next slide, please. So relating to violence that occurred in childhood, this is individuals who were adults and reported this experience in their childhood. The slide is set up the same way as the lifetime violence slide. And here you see close to 16% of the females and 21% of the males experiencing childhood violence. The pattern with sexual violence being more common for females, physical violence being more common for males, and emotional violence being similar in both age groups, that pattern is similar with childhood violence as well. It's important to note that for the females, 7% of them reported that their first sexual experience was coerced, pressured, or forced. Next slide, please. So who are the perpetrators of this violence? This slide shows the perpetrators for the females, starting with sexual violence. Most commonly, this was perpetrated by family members, and we report just on the first incidence of sexual violence, and then followed by current or ex-partners and people in the neighborhood. Because of this pattern, the violence then occurred more commonly at home for 66% of the females, or at an outside location like in the shops or at school. And this sexual violence included mostly unwanted touching and unwanted attempted sex. Physical violence for females was most commonly perpetrated by current or ex-spouses, followed by parents or relatives. And emotional violence, in the next slide, was most commonly perpetrated by a peer or a current or ex-partner. Next slide, please. The same slide for males, sexual violence in this instance was most commonly perpetrated by classmates or schoolmates or friends, followed by current or ex-partners. And so then the incident of the location of the first incidence of sexual violence was commonly at home or at school. And again, this mostly included unwanted sexual touching and unwanted attempted sex. Physical violence, in the next slide, was also most commonly perpetrated by a classmate, a school or a schoolmate or a friend. So a peer, followed by a parent or an adult caregiver. And then in the last slide, Emotional violence was also most commonly perpetrated by peers. Next slide, please. So in terms of who sought or received services for lifetime sexual violence, here in this slide, the females are in pink, the males are in blue. And you see that about 2/3 of the females did tell someone, half knew where to seek for services, but very few are still seeking services and getting help. For the males, for sexual violence, under half told someone, and just over close to 60% knew of a place to go, but we didn't have sufficient data for the estimates of who sought help. Next slide, please. In terms of disclosure and services sought for physical violence, the pattern is pretty much similar for the females, in that the majority tell someone and know of a place to go, but very few seek help. And here now, for physical violence, which is the most common violence for males, you see that half told someone, or 80% knew where to go, but still just 20% sought services and 17% received them. Next slide, please. We then examined in bivariate analysis what characteristics might be associated with experiencing physical violence, physical or sexual violence, starting with individuals who are still children during the survey, so 13 to 17. We looked at orphan status, school attendance, employment, witnessing violence, food security, and disability. And the pink is females, the blue is males. What this table shows is the proportion who experienced violence by characteristic. If you enter, next slide. So witnessing violence, you see that the proportion of violence among youth who'd witnessed violence at home was substantially higher than among youth who had not witnessed violence at home. Next slide, please. And for female participants, the proportion with disability who experienced violence was substantially higher when we compared with youth without disability. Next slide, please. In this next slide, we look at the same variables for individuals who were adults during the survey, so 18 to 24. The same variables around orphanhood. This time we added education, employment, witnessing violence at home, marriage, food insecurity, and disability. And in the next slide, we see that witness of violence is substantially higher, even for this age group. For violence is higher for those who did witness violence at home. Next slide. We see that females who were married had a higher proportion experienced violence compared to those who were not married or cohabiting. And next slide. And here we see males with disabilities having substantially higher experiences of violence. The pattern was the same for the females, but the confidence intervals overlap. Next slide, please. So just moving on to the impact of sexual violence on mental health. The pink graph is females, the blue graph is males. The red bars is people who experienced sexual violence, and the people who did not experience sexual violence in green. The bars are set up the same way. And what this slide really clearly shows is statistically significant differences, higher mental distress, and higher intentional self-harm, and higher suicidal ideation among individuals who'd experienced violence compared to those who had not experienced sexual violence. Attempt of suicide, those confidence intervals overlapped. The pattern is pretty much similar for the males, just that we had smaller numbers and a bit more unstable estimates. Next slide, please. And also just continuing to look at the impact of violence. Here we looked at who missed school due to childhood sexual violence, and around 9.8% of the females missed school. We had an unstable estimate for males. Those who missed school due to physical violence, we had 12% of girls and 9% of males missing school. And quite importantly, 4.5% of the girls reported that they had a pregnancy arising from an incident of sexual violence. Next slide, please. So finally, I believe this is finally, looking at HIV prevalence in the survey, we had 3.3% of our survey respondents testing HIV positive during the survey, and we had double that number of females testing HIV positive. When we looked at HIV status according to those who had experienced violence, our survey did not reach statistical significance in terms of those who experienced violence and those who did not experience a lifetime of violence. When we look at sexual violence, we see that 9.2%, HIV prevalence was 9.2% among those who are experienced a lifetime sexual violence versus 6.4% for those who did not experience this. But again, those confidence intervals overlap. Next slide, please. So at this point, I want to hand over to Michelle Lee with the CDC, who will take us through the rest of the results and conclude the presentations. Thank you.
Great. Thanks so much, Dr. Harriet. So jumping right in, you'll recall that earlier in the presentation, we mentioned the fact that this is Eswatini's second violence against children survey, the first one having been completed in 2007. So the natural question I think to follow is, well, what do the data show in terms of what's changed between 2007 and 2022? Have we seen improvements? Are we trending in the right direction? And we want to acknowledge the fact that since it's been 15 years, 15 years have elapsed since the first survey. There have been methodological improvements, including extensive questionnaire changes. The comparisons are limited to a few indicators that could be consistently measured across the two surveys. Importantly, as well as we look at these results, the comparisons are limited to females only, as males were not included in the 2007 survey. So with that in mind, and if we want to go ahead and advance one more for the footnotes, when we look at sexual violence, there were significant reductions in pressured or physically forced sex at sexual debut. So you see that in that first bar on the chart with 55%, and when in 2007 having reduced to 17% in 2022. We also saw significant declines in all forms of lifetime sexual violence. And as you see for the remainder of the bars on the graph, this includes any sexual violence, unwanted sexual touching, unwanted attempted sex, pressured sex, and physically forced sex. And all of these reductions were significant in nature, statistically significant. Next slide. For physical violence, on the left-hand side of the slide, you see that there were significant declines in the prevalence of physical violence by an adult from 2007 to 2022, including in lifetime physical violence and childhood physical violence, that having dropped from 22% in 2007 to about 4% in 2022. And just for reference, Dr. Harriet touched upon this earlier, but lifetime violence is assessed among the total surveyed population of children and youth for the ages of 13 to 24 years. And childhood violence is assessed among youth aged 18 to 24, and understanding what their experiences in childhood were before the age of 18. Now, looking at the right-hand side, in terms of emotional violence, we are seeing significant declines here, as well as in the prevalence of emotional violence by an adult. This including lifetime emotional violence and childhood emotional violence. We do caution the interpretation of the differences, given some variation in question wording between the 2007 and 2022 surveys. Next slide, please. So if we were to envision a community where children and young people are free from violence, what does violence prevention look like? There's a technical package called Inspire that presents 7 evidence-based strategies, really aiming to help intensify focus on prevention programs and services with the greatest potential to reduce violence. And that's with an aim to achieve such a vision. It was developed and launched in 2016 in partnership with 10 international agencies. And a core feature of that Inspire framework is that data should drive what we prioritize for prevention and how we go about it. So in essence, data serves as a starting point for preventing violence. In that regard, the survey included some questions that inform key Inspire indicators. Dr. Harriet made mention to this earlier, with the expectation that it helps to identify some key opportunities to inform evidence-based interventions and approaches. So the data that you see here in the slide are a subset of the measures that were included in the survey. And I'll just highlight a few of these. So for example, under the strategic area of parent and caregiver support, we looked at positive relationships with mothers as we explore potential protective aspects of parent-youth relationships. And we see that whereas reported percentages were high for both males and females, interestingly, more males than females reported having positive relationships with mothers. If we were to look at income and economic strengthening and further assess food insecurity, we learned that experience of food insecurity is high, and that about 3 in 5 females and males ages 13 to 17 years experienced food insecurity here in Eswatini. Zeroing in on risk factors among young adults, the data show us that more males, at about 11.3%, more males than females, 11.3 compared to about 5% for females, ages 18 to 24 had early sexual debut, and that's sex before the age of 16. And then looking at norms and values, we see that more males than females endorsed traditional gender norms. Next slide, please. Expanding a bit further on norms and values, the results showed high percentages of agreement for both males and females that corporal punishment by parents and teachers were necessary. You see that on the first set of bars, the first 2 set of bars in the graph, with males coming out in higher agreement, more so than females. More males also aligned with attitudes that were supportive of domestic violence. So you'll see that with males at 16% and females at 14%, females did not trail far behind. Next slide, please. So in summary, we've gone through a lot of information, but here are just some key high-level takeaways. There has been significant decline in the prevalence of sexual, physical, and emotional violence in the last 15 years since the first survey in 2007. Now, of course, this is limited to specific variables that were comparable. However, the directionality of the declining trend is quite notable. Despite these notable reductions, what the recent survey data do tell us is that violence against children and youth is still prevalent, and it remains an urgent situation in Eswatini, and it demands attention. Adolescents who experience violence are not getting the support and services they need, not because they don't know where to go for help, but because they are not taking the important step of seeking it. And as a nationally representative survey, the VACS is a rich data source with detailed data on the context of violence against children and youth in Eswatini. It offers us an important opportunity to use updated data, updated evidence to inform programmatic and policy efforts, to respond to and also to prevent violence. Some additional survey strengths, again, Harriet made reference to these, but the survey used a split sample approach where the survey for females was conducted in different enumeration areas than the survey for males. Again, this helped protect the confidentiality of participants by eliminating the chance that opposite sex perpetrators would be interviewed in the same community, potentially discover the purpose of the study and possibly retaliate against participants. And then again, as mentioned, same-sex interviewers were also utilized for both males and females. And we believe that this promoted a more comfortable environment and therefore hopefully more truthful responses to the survey questions. And then finally, given the multi-sectoral nature of violence against children and youth as an issue, we see that the intersectoral engagement, the multi-sectoral engagement of stakeholders, we see this as a critical aspect of local ownership for the survey, for the results, as well as for the data use actions that follow. Next slide, please. So just moving on and touching upon some of the limitations of the survey, we recognize that it is a household-based survey, so some vulnerable populations have been excluded or missed. So for example, this includes children residing outside of households, such as in care homes and residential institutions. And as well, though, children and youth with disabilities were intentionally included within the survey here in Eswatini, we recognize that certain types of disabilities disqualified some from participating. Additionally, we recognize that when individuals reported multiple instances of a form of violence, the survey only collected contextual information on the first and most recent episodes of each type of violence. So this potentially results in missing important contextual detail on certain violent events that are affecting the participants. We recognize that the VACS is also vulnerable to recall bias. The study did not include participants over the age of 24 years old, and that really was to maximize their ability to recall events from childhood. However, there's still a chance that participants do not accurately recall all of the details of their past experiences, victimization experiences. And then finally, we acknowledge that some participants may not have been comfortable disclosing personal and sensitive life experiences with strangers. So this may result in an underestimate of certain experiences. Next slide, please. So an excellent practice is that VACS survey implementation is done alongside an intentional effort to support development of data-driven, evidence-based, and actionable recommendations in an effort to really enhance national actions to address violence against children. And this is what we call a data to action, or you'll see it referenced as a D2A process. It's really grounded in the fact that the survey does generate evidence that violence against girls and boys is a knowable and solvable problem. And we really want to be able to generate momentum for use of these data in efforts to propel policy reform and strengthen programs for prevention and response efforts. Next slide. We know that a strong government-led multi-sectoral coordination is the single most important factor in translating VACS results into positive action for children. And the fact that the agenda for child protection is really a shared responsibility of critical importance, but it really requires collaboration across many vital sectors, which you see a handful listed here on the slide, and that representation may look a bit different in any given country. So in order to effectively catalyze national action in response to the data, the D2A process really seeks to bring together stakeholders to understand the new data, to discuss priorities, and commit to and collaborate on actions to be taken. Next slide, please. So to this end, following some local dissemination of survey results, Eswatini held 2 workshops focused on VACS data to action and national action planning. This was done under the leadership of the Deputy Prime Minister's office, this office was the lead government agency for VACS and the lead government agency for children in Eswatini. Multiple sectors, all of whom you saw referenced on the prior slide, plus some, were represented and really gathered together in common purpose. The recent VACS results, the 2022 results, were reviewed. Priorities for heightened prevention efforts and response efforts were identified and discussed. And then opportunities for enhancement and potential development of new or modified programs and policies were also discussed. One of the great benefits to having all of the sectors represented in the room was that in as much as sector-specific discussions and planning efforts was important, having the ability to foster necessary collaborations across sectors and have those discussions, we saw was of great benefit, and of course is necessary for greater impact. So following these 2 workshops, the government has committed to continuing to advance the work that was started in alignment with and under the umbrella of the latest national strategy to end violence in Eswatini. Next slide. So we also know that various launch and dissemination activities are quite key to raising awareness and commitment. So to this end, this slide just highlights some of what Eswatini has done in taking advantage of different platforms to raise awareness and speak to the latest evidence generated by the survey. This included some national report launches for both the priority indicator report and full report, dissemination of results to high school students or high school head teachers as a key stakeholder group in the community, and leveraging various media platforms and opportunities such as the 16 Days of Activism Against GBV. Next slide, please. So in conclusion, I'd say that Nelson Mandela's wise words have served as an important reminder for us in undertaking this work. He said, safety and security don't just happen. They are the result of collective consensus and public investment. We owe our children, the most vulnerable citizens in our society, a life free of violence and fear. So under the leadership of the government of the Kingdom of Eswatini, the different, all of our key stakeholders have really rallied together with hopes and expectation of really making progress towards this type of future. Next slide, please. And in closing, we know that this work doesn't happen without a whole village supporting it, all with different individuals with key roles to play. So want to acknowledge all of the individuals across the Eswatini government, ICAP and CDC HQ, as well as country offices, other collaborators, field teams, survey participants, who, despite the sensitive nature of the survey, shared their experiences with us. And a big thank you, I think if you just advance one more, a big thank you to Ms. Sipiwe Shongwe from the ICAP Eswatini office. She served as the study manager for the 2022 VACS survey, but was also very instrumental in the development of today's presentation. So next slide, and with that, we thank you, Siyabolga.
Well, thank you very much. I want to thank our 3 speakers for really this superb presentations today on this very important topic. It's wonderful to see how data are taken into action, as you said, Michelle. And obviously, it's evident how the data prior survey also helped were taken to action, and maybe that's why we see the improvement in the results. There's several questions. I'm going to start by picking a few of them. One of them is, have there been similar decreases in violence noted, violence against children noted in sequential surveys in other countries? Or is this uniquely something that's been that you're seeing now in Eswatini?
Right. Waf, I think I'm seated together with Mpo, so we'll sort of discuss and I can be the spokesperson for the Eswatini team. So I think the one survey we had a look at was, one country we had a look at was the Kenya, that did this in 2010 and 2019. Less time had passed between the surveys, and they did have reductions close to like halving of certain variables, but I think what we see in Eswatini is substantially larger. It is over a longer period of time, and it is after the efforts that Mpo described in terms of mitigating violence. So I do not know of any other country that has such substantial decline, but at least in one other country, we do see some progress with mitigating violence against children.
Great, thank you. Another question is obviously the questions in this survey are extremely sensitive and so on. And there's a couple of questions about, how did you manage to be able to do these surveys, have the surveys be done in a confidential context, and then assuring the participants of the confidentiality and security of the data and so on?
Yeah, that's a great question. I think the biggest piece is by CPWeb, mostly training, and more training. We have extended training on this issue, on being sensitive, on how to handle issues when, participants start to recall issues and how to handle information that's given to interviewers in the survey. All interviewers signed confidentiality agreements. We went to great lengths to secure a private location at which to conduct these interviews. We scheduled appointments that were convenient to facilitate privacy. And we even had a sort of like a fallback position where if somebody sort of like barged in, we had an alternate script sort of to change the topic if ever, there was an interruption. But we went to great lengths with how we trained samples, how we prepared communities, and how we conducted the surveys to ensure that privacy was protected. We then did not collect really PII or PHI that was linked, PII that was linked directly to the survey. Any identifiers we collected was sort of for purposes of referral to Mpo's department for social work and social welfare, and to one of our other collaborators within Ministry of Health for healthcare and support. As well, when we were in the field, we didn't say we were the VACS team. We had an alternate name, which I won't say on this webinar, but we didn't go into the communities, saying we were a VACS team.
Okay.
Thank you.
No, that's great. I think there are amazingly important lessons learned here. One other question is, I think it was highlighted, I believe, by Michelle in the end, is that while substantial proportion of the participants, they kind of knew where to seek help, but they didn't seek it, or they didn't seek it for a variety of reasons. It's almost reminiscent of the cascades that we have for care and treatment. Like you need to get sort of optimize every step of the cascade. And I'm just wondering, in terms of that, the terminal part, the latter part of the cascade of knowing where you can get help and actually going there and seeking help and having the help be responsive to the need. Can you say something about how you're trying to tackle that particular step in the cascade?
I will hand this over to Michelle to make a contribution, but what we can say very briefly is that the majority cited guilt, embarrassment, or fear of the perpetrator. About 1 in 3 reported that as the reason they did not seek help. And the rest were sort of thinking, just interpersonal barriers or their beliefs about what help they would get if they did seek services. Very few, less than 6% reported structural barriers. I think Michelle may have some thoughts about how this is being addressed in the data to action activities. Over to you, Michelle.
Thanks, Harriet, and for the excellent question. I mean, I think this is an ongoing area of exploration, especially as we really discuss across the sectors who have responsibilities within the kind of response framework and provision of services, whether in collaboration or separate to those who seek it. And trying to understand, to what extent is it clearly not lack of awareness, but and we do believe it's less in the way of structural barriers, but are there some that still potentially remain? Is it more of the feeling that there's maybe a lack of a welcoming environment? And how might that be addressed? Are there other types of factors? I have to say this is an area of robust discussion, both across the government sectors that are engaged, but as well as the various implementing partners who are supporting areas of work in this space. So I don't know if we can come with like a definitive answer in terms of what exactly is currently planned. Part of it is a little bit of finding and discussing what we believe to be some optimal best practices, especially in the way for those who are seeking those services, and then understanding to what extent we can kind of strip away any barriers, whether they're structural or not, for those that are not seeking it. So this is definitely an area under development as we continue with the national action planning efforts.
Yeah, thank you. And certainly I would imagine that just sharing the results of the survey widely, the dissemination activities that you described, Michelle, and others, is that in and of itself allows for people to appreciate the gap, that exists, and maybe will motivate some people to who would otherwise not have sought the services to hopefully seek such services. So that's another value of just disseminating the survey results overall. I think we have time for maybe one quick question, and that has to do with just some of the questions regarding the methodology, like, for example, whether the uptake of the survey, the participation rates in the 2007 versus the most recent survey, were they similar at least similar in terms of the two sequential surveys?
Hi, Wafa. Yes, we double checked. Both surveys had response rates above 90%. So that was similar. And to another individual who asked about, do we think it's a methodological issue? The questions we compared were asked in a similar way, in a similar population. So what we presented are what, of course, we can't determine cause and effect, but those are sort of true differences, not methodological differences. Thank you.
Thank you. Well, I want to end by thanking all of you for the presentation, and also, and as well as for all of the individuals who attended the webinar today. I think this was very important information for all of us to have. I think also want to really congratulate Eswatini for the progress it has made in terms of tackling violence against children and adolescents, and in some way is Eswatini is again leading the way in terms of being determined to address a problem and trying to seek a way forward so that we can really get to zero tolerance for such violence. So thank you all very much. And as always, we always share the recordings of these webinars and the slides on the ICAP website. I want to let you know also to please put on your calendars. We have another interesting Grand Rounds is scheduled for Thursday, November 30th at 9 a.m. Eastern. And this webinar will focus on AI, artificial intelligence, and digital innovation in public health. So please plan on attending the next webinar with all of us. Thank you and have a good day.
Thank you.